Okay, so I'm going to talk about the role of aging in arthritis, and because osteoarthritis is the most common form of arthritis, clearly associated with aging, most of this talk is around osteoarthritis. The other reason is that's what I know about the most is osteoarthritis, since I've been working on it for over 25 years. But I thought I'd have a couple slides at the beginning just about rheumatoid arthritis, because there is some information about the relationship between aging and rheumatoid arthritis as well. So, starting with rheumatoid arthritis, as you can see, if you look at the incidence of rheumatoid arthritis, it does go up with age. There are different presentations of rheumatoid arthritis depending on age. So this graph starts with adults at the age of 18. As you may know, there are pediatric forms of what we might call rheumatoid arthritis that are sometimes called juvenile inflammatory arthritis, or JIA. So that's not included at all on this. So this is just adults starting at age 18. So it does increase in incidence with age. There are some differences, though, between older adults who have new onset rheumatoid arthritis versus younger adults. So in young adults, you know, the ratio of females to males is about 3 to 1. Whereas in older adults, it becomes more common in males. And so the gender distribution is closer to 1 to 1. In older adults, there's more often an acute onset of rheumatoid arthritis, whereas in younger adults, it's usually a little bit less acute, sort of subacute. And older adults have more involvement of large joints like shoulders and knees than younger adults. And it may start as polymyalgia rheumatica. Have you heard that term before? Did you have sort of the Arthritis 101? Did they talk about PMR? So PMR, polymyalgia rheumatica, this is a condition that's seen in adults over the age of 50, and it's characterized by shoulder and hip girdle soreness and stiffness, and an elevated SED rate as an inflammatory marker. And PMR is not something you'd see in a young person, not seen in people under the age of 50. Why it starts sometime after age 50 is really not clear. And the way it's diagnosed is they have these typical symptoms of a lot of shoulder stiffness, hip girdle stiffness, and the high SED rate, and then they respond really well to low-dose steroids. So you give them 10, 15 milligrams a day of prednisone. Somebody with polymyalgia rheumatica feels so much better afterwards. And that's sort of one additional part of the diagnosis for PMR. So it may start as something with looks like PMR and then evolves into rheumatoid arthritis. And then this weird thing here, RS3PE, this stands for remitting, symmetrical, seronegative synovitis, those are the 3 S's, with pitting edema. So this is a condition where older adults present often with like a whole lot of hand swelling and pain. So they have swelling that's almost pitting-like, and they have synovitis and so on. And it can kind of come and go. It's not very common, but it can be sort of a precursor to rheumatoid arthritis. And again, it's not a presentation you see in a younger person. In older adults, there's a lower prevalence of a positive rheumatoid factor. So in younger adults, around 80% of people with RA have a positive rheumatoid factor. The other 20% are sometimes called seronegative. In older adults, it's closer to 66% have a positive rheumatoid factor. I don't have data on the CCP, the citrulated cyclic peptide. If you heard of the anti-CCP, it's another antibody that's seen more commonly in rheumatoid arthritis. And I don't know if that's the same difference between the animals. Older adults tend to have higher levels of interleukin-6 and lower levels of tumor necrosis factor alpha associated with the RA. And IL-6 is sometimes called the gerocytokine, because there's lots of data that show that your systemic levels of interleukin-6 go up with age for a number of different reasons. And then older adults have a worse outcome and more comorbidities. Yes?
So would that mean that TNF-alpha inhibitors are less effective in older adults?
Good question. Not necessarily. And so there doesn't seem to be a huge difference as far as I know, although it's probably not really well studied in terms of response to TNF inhibitors in young We still use them in older adults. Now that we have anti-IL-6 available, that may be something that would be used more in older adults. Currently, it's not for rheumatoid arthritis. It's used similarly, but for conditions like giant cell arteritis, which is also associated with high levels of interleukin-6, anti-interleukin-6 is now being used as one of the treatments. And why rheumatoid arthritis is more common in older adults has to do with aging and the immune system. So there are a number of different changes, both in the innate immune system in this box and the adaptive immune system in the other box, that change with age that make it more likely that you can get rheumatoid arthritis. So innate immune response, things like cell migration, phagocytosis, the ability to kill microbes, that's not really closely related to ROA, but that's something that does go down in older age, and that's one reason why older adults get more infections. There's an increased production of some of the inflammatory mediators. We talked about IL-6 as being one of the major ones. So there seems to be more of these cytokines that are more made at higher levels in older adults. And then there's this chronic low-grade inflammation that occurs with aging. Sometimes that's called inflammaging because it's been documented in a number of different studies and observational studies, and it seems to be related to this elevation, particularly in IL-6. And then adaptive immunity, there are changes in T cells, B cells, both memory T and B cells, changes in the T cell receptor diversity, turnover of CD8 positive cells, changes in NK cells. So we don't have time to go through all of this, and I'm not a great immunologist, so I can't explain all these differences, but basically there are a number of different changes that occur in adaptive immunity that make it more likely that you get autoimmune conditions with age. So now the rest of the talk is really going to be on osteoarthritis. And if you've heard anything yet about osteoarthritis, get a talk.
We just have to go to the Arthritis 101.
The Arthritis 101. Okay. So I'm not sure how much OA was covered. So if anything's repeated, then that's okay. It's still benefit, I think. So basically, to start out with, this is a diagram of a normal knee joint. And I think you know by now that the cartilage is the tissue that's on the surface of bones. What do you guys think cartilage is there for? So cushioning is what people often think about when they think of articular cartilage, but it's not really a true cushion or a shock absorber because it doesn't have the biomechanical properties to absorb load. What it's primarily there for is to provide a nice smooth surface to bones so that your joints glide over each other when you're moving your joints. So the surface coefficient of friction of articular cartilage is very smooth. It's less than, say, ice on ice. So it's a very smooth, slippery surface. The load, cartilage is compressed when you load your joint, say when you're walking, but the load is actually absorbed by the underlying bone as well as muscles that help support the joint. In the knee, the meniscus absorbs some of the load. So the load is sort of distributed throughout the joint and not really absorbed by the cartilage itself. So it's not really a true shock absorber or cushion, but people often think of it that way. So as osteoarthritis develops, the cartilage breaks down. So you can see there's a loss of staining, and it's nice and purple because all the proteoglycans that are in the matrix, and you get these clefts that form. You can see also how thick the bone underneath the cartilage is. So you have normal bone, thick bone. If you did an X-ray on this is where you see sclerosis on an X-ray. It's this thickening in the bone under the cartilage. Here, there's even a little piece of cartilage that's been pushed down into the bone. On an X-ray, this would show up as a bone cyst because there's an area where there's a loss of bone where the cartilage is. And then just looking at it diagrammatically, you can see the osteophytes that form on the joint margins, which are common in osteoarthritis. There's also some level of inflammation in the synovium and some thickening in the synovial capsule. So if you see someone with osteoarthritis in their hands, for example, you see these knobby joints in the DIPs and the PIPs. That's from the bone changes as well as the changes in the joint capsule, making the joint look bigger. And the same thing you can often feel in a knee with somebody with osteoarthritis is an enlarged joint. And just diagrammatically, how osteoarthritis progresses from normal to sort of the advanced stage, you can see that there's sort of a progressive loss of the articular cartilage. Early on, there's actually some swelling. Because of the loss of the collagen structure, it allows more fluid to come in. And then as it goes on, there's this fibrillation of the cartilage surface. And you can see how the bone is becoming thickened. And advanced osteoarthritis, the cartilage is gone, the bone is thick. And one of the problems currently with osteoarthritis is that when we see patients when they're symptomatic, they're often at these more advanced stages where they have significant damage. These very early stages are asymptomatic, and part of that is due to the fact that there are no nerve endings in cartilage. So this very early surface damage to the articular cartilage, you wouldn't actually feel that. You only get pain in the joint once other structures are involved, the bone, the synovium, and so on. That's where the pain comes from in osteoarthritis. So the interventions that we have for osteoarthritis, they're often used in people that have more advanced disease. None of them work to slow disease progression. So all of the treatments that we currently have available for osteoarthritis are symptomatic treatments to help reduce pain and try to improve function. So non-steroidals, exercise and weight loss, none of those interventions actually affect disease progression. And once you get to this advanced stage, that cartilage is gone. You're not going to put it back again. The body's not able to repair and replace the lost cartilage. So in the future, what we would really like to do is start interventions at this earlier stage to prevent it from advancing to the end stage. So for that, we're going to need some intervention that slows disease progression, and then ways to detect earlier disease, such as imaging like MRI. When someone's at that advanced stage, then joint replacement surgery is really the best treatment and the only thing that really works.
So, sorry, is there evidence that you can prevent the worsening?
No, not, well, there's some epidemiologic evidence that you can prevent or slow progression by things like weight loss in someone who's obese. We're actually planning a trial right now called TOPS, the Osteoarthritis Prevention Study. This is with Steve Messier at Wake Forest. This is one of the trials that Lee Callahan mentioned recently. We're going to take people that are at higher risk for osteoarthritis but don't yet have OA and see if we can prevent it by exercise and weight loss. There's no pharmaceutical intervention at this point in time that's been shown to prevent it or to slow it.
So we think that behavior modification may.
Currently, that's our best chance, right? Until something comes along that really affects the disease process.
What are these images from?
Oh, okay. So these are histology images. So this is human articular cartilage that's been taken out. The normal stuff is from a tissue donor who died and got a joint. The other tissue like this is from someone who's having a joint replacement. So you do histology, you make a slice through the cartilage and stain it, and you look at it. So in terms of aging, you can see that there's a direct association between increasing age and percent of the population that's affected by osteoarthritis. And these different lines represent different ways of looking at changes in the joint and symptoms. So this black line this is a very old autopsy study that was done where they looked at the knee articular cartilage for any signs of changes in the cartilage, and you can see how common it is in older adults to have some changes in the articular cartilage, but this wouldn't be defined as osteoarthritis because these people may or may not have had any symptoms. The red is radiographic osteoarthritis in one joint. So this is a study that was done in England where they went around with an X-ray machine and X-rayed over 1,000 people, hands, spine, knees, and hips, and just determined whether or not they had radiographic evidence of OA in at least one joint. And you can see again how that increases with age. By the time you're 80, over 80% of the people have some radiographic evidence of OA, but may not have symptoms. So if you look at self-reported arthritis, people that have symptoms and may have some problems with function, that's about half of what people have in terms of just radiographic OA. So you can have some early radiographic changes and no symptoms at all. And then if you look at self-reported activity limitation, arthritis is bad enough that it interferes with their activity. You can see it goes up with age, but it's a lot less common than the radiographic OA. And in terms of the prevalence of some of these findings that you see in the joint on MRI, this is a study that looked at people that had no symptoms and no history of joint trauma, and just did MRIs to see were there changes in the joint. And what they found was that features of osteoarthritis, defects in the articular cartilage, like here's a defect in the cartilage, meniscal tears, bone marrow lesions. So this is a bone marrow lesion that you can see on MRI. These are common findings in people with osteoarthritis, as well as osteophytes, that 4 to 14% of adults under the age of 40 and 19 to 43% of adults greater than age 40 had these changes on MRI. Remember, these people are not symptomatic. So this tells you that there can be changes in joint structure that are occurring that may not result in symptoms. And that's one of the big conundrums around osteoarthritis. If you're going to use MRI as a tool to treat people, you may be picking up people with some of these lesions who don't have symptoms. What you really want to know is who are these people with these OA features that are going to progress and become symptomatic? Because if you're going to enter them in a trial, those are the group that you want to have. So this is just something to keep in mind. Then the effects of age on osteoarthritis interact with some of the other risk factors. So this is a nice study from Elena Lucena. This is the prevalence of symptomatic knee osteoarthritis and age. And you can see this black line are women who are obese. So you can see how their prevalence goes up with age relative to obese men and then non-obese men and women. So all the groups, they have an increased prevalence with age, but then the additional risk factor of obesity multiplies that. So you can see that's the group that's at highest risk. And I have this arrow here because if you look after about age 50 or so, you can see that the prevalence of osteoarthritis really starts to rise. So it's less common in older adults, but somewhere around 50, something happens with our aging bodies that make osteoarthritis become more and more common. Then some more epi data. This is an interesting study of medical students at Johns Hopkins that was started many, many years ago. And they did a survey and asked the medical students about a history of joint injury. And then they've been followed up over the years. And this is the cumulative incidence of symptomatic osteoarthritis. And if you compare the people that had an injury when they were young in medical school versus those that didn't, you can see no injury group, again, it goes up with age, but the group that had an injury, it's much more likely to increase with age. So obesity plus aging, joint injury plus aging, these are all factors that result in higher prevalence of osteoarthritis in the knee. And then finally, this is another study looking at people with joint injury and how quickly they develop osteoarthritis and how that relates to age. So this is an osteoarthritis score. This was a study done in Sweden where they did arthroscopy plus radiographs. And they kind of cut this line here at a score of 6. These were people that had radiographic evidence of osteoarthritis with sclerosis and some joint space narrowing. So basically what you can see in red, if you have your joint injury at an older age, greater than 30, which is not very old, you develop OA much more rapidly than if you have your joint injury at a younger age, which is the blue side here. And on the top, it mentions that if you have a meniscal injury between the ages of 17 and 30, the average to develop OA is 15 years. But if you have your meniscal injury after age 30, the average is 5 years to develop OA. So again, there's something with aging that is affecting the development of osteoarthritis and how fast it occurs as well.
Does this factor in if you had surgery or not?
Surgery doesn't seem to make any difference. So for example, ACL injuries, where you tear your anterior cruciate ligament, whether you have surgery or not, doesn't affect your risk of getting osteoarthritis later. So ACL repairs are not being done to prevent OA, they're done to stabilize the joint. They're done in athletes so they can go back out, play again, but it's not preventative. And there's a lot of work being done to figure out how to better treat someone with an ACL injury to prevent OA. But right now, the surgery doesn't really help. Same with meniscal injuries. You can do whatever you want to the meniscus operatively. It's not going to prevent OA. In the old days, they used to actually take out the meniscus if it was injured. They found that if you take out the meniscus, you develop OA really rapidly. So that was a really bad technique, a total meniscectomy. So they don't do those anymore. So, for many years, osteoarthritis has been called, wear and tear arthritis. You've probably heard that before. Degenerative joint disease is another name. And this is, from a 1955 review article where they talk about it being degenerative joint disease. And basically, there's a wearing of the cartilage with a reactive proliferation of the cartilage in the bone. That was sort of how OA was thought. And it's almost like your joint is an automobile tire. And, you just wear it out because you're using it over time. Well, I think if you just think for 1 minute about all of this, you can see why your joint is not anything like an automobile tire, right? Your joint's a living tissue. And so it's not like an inert tire that's just going to get worn out. To develop arthritis, there's got to be more to it than just wear and tear. So we've really learned over the last 25, 30 years that osteoarthritis is an active biological process. It's not wear and tear. So we don't like to call it degenerative joint disease anymore. We really like to call it osteoarthritis. And the itis part, emphasizes inflammation having a role. So there's a whole number of risk factors. We've been talking about aging, and that's the focus of this talk. But genetics, gender, obesity are also risk factors for osteoarthritis. And there are biomechanical factors, malalignment, so like if you're knock-kneed or bow-legged, you're malaligned, you're more likely to get osteoarthritis in the knee. Joint shape was really important in hip OA. Again, obesity is a mechanical factor and a systemic factor, joint injury. So these are all various risk factors for OA. And then there's the different tissues that are involved. So it's not just a cartilage disease. The meniscus is damaged. The bones change, as I've already shown you. In the knee, it's really common to have tears along with it, like an ACL tear, even without a history of trauma. So it's sort of a degenerative tear. And then there's a variable level of synovitis in people that have osteoarthritis. So it's really a whole joint disease. So it's not just wearing of the cartilage. And there are a whole host of cytokines, chemokines, various types of growth factors, and MMPs or matrix metalloproteinases that are involved in this disease process that are responsible for breaking down the various joint tissues. Some of them are being produced by a damaged meniscus or synovitis, and some of them are produced in cartilage. So it's sort of this soup of these inflammatory factors that are present in the joint that are responsible for the breakdown of the tissue. And that's important to understand because it means that we can have a treatment that will slow disease progression if we discover the right mediators to block. And that's the part where we haven't passed yet. So like rheumatoid arthritis, they found that blocking TNF-alpha makes a really big effect, at least in some patients. And now blocking IL-6, for example, has a big effect. In osteoarthritis, so far blocking TNF-alpha has no effect. IL-6 hasn't been studied yet. Blocking interleukin-1 has no effect. So we haven't really found a master driver for osteoarthritis yet, like they have for rheumatoid. But, I think we'll get there. And as I mentioned, the subchondral bone is really important because it's producing factors that also affect the cartilage as well. So again, it's a very complex disease that involves the entire joint. In terms of the mechanical factors, I think this is a very dramatic demonstration of how mechanics, even in the hands, are important in osteoarthritis. So this is a 93-year-old who'd had a stroke on the right side when she was 33. So compare her right hand to her left hand. This was the osteoarthritic changes called Heberden's nodes, that's bony changes. You can see that here on the x-ray. Her right hand, perfectly normal. So she developed osteoarthritis only in one hand, because normally this is bilateral when you get these Heberden's nodes. And it was in the hand where, you know, she had the stroke. So there's a definite mechanical component to osteoarthritis. And the mechanics of osteoarthritis is not just loading with weight, like your knees and your hips, because this is involving the hands too. So what the mechanics are is the stress across the joint. So when you grip or you bend your fingers, there's a lot of stress across your DIPs and PIPs. And the stress is just the same amount as in your knee. And that's why osteoarthritis of these joints is common as well. So it's not just, you're not like walking on your hands, right? But you know, you're compressing those joints when you're gripping or moving them. And the reason why these joints seem to be affected more than, say, the MCPs is the surface area of these joints is much smaller. So there's less area to kind of distribute load. So it's felt that that plays a role in where osteoarthritis occurs. So here's a quiz. Can anybody looking at this x-ray tell me what kind of arthritis this is? It's probably a medical student question, but if you look at the x-ray, you focus out there on those joints and then also look at these, what do you think you see there? It's a form of osteoarthritis, good. What form is it? Is it typical osteoarthritis? Based on what you heard in Arthritis 101? What's unusual about, say, something right in here, some of those joints out there? There's erosions into the bone. Yeah. So you can see how there's sort of this gull wing appearance to the joint. This is called erosive osteoarthritis, and this is seen more commonly in older adults and more commonly in women. So there's erosions that are central erosions in the DIPs and the PIPs, whereas the MCPs are pretty normal, no erosions at all. Rheumatoid arthritis, you get erosions in these joints. Erosive OA, it's in the distal joints. And in OA, it's a central erosion, say here, as opposed to in RA, the erosions are peripheral. And then in OA, you get osteophytes and all those other bony changes, which you wouldn't see in RA where you get bone loss. So this is erosive osteoarthritis. About 5% of hand OA is erosive. So it's a more disabling and more inflammatory type of OA. Okay, so knees. So can you tell me what you see on these knees that kind of stands out? Something.
There seems to be less joint space on this side.
Somewhat less joint space, yeah. But is there something else within the joint space?
Pointy.
This is normal, but there's something. What's this stuff? Yeah, so this is called chondrocalcinosis. Have you heard that term before? So chondrocalcinosis is calcification that occurs within the meniscus as well as the cartilage. This is in the meniscus, and there's some in the cartilage here. You can see a nice meniscus that's calcified. Chondrocalcinosis, again, occurs primarily in older adults. You don't see this very often in younger adults. It's associated with crystals, calcium pyrophosphate crystals. And when these crystals break off and they're in the joint, you can get something called pseudogout. So it's a crystal disease where you get a flare with inflammation and swelling in the joint, but it's not from gout crystals, it's from calcium pyrophosphate crystals that are associated with chondrocalcinosis. And then this can be seen in association with OA, or it can be seen on its own. Again, another arthritis problem in older adults. So in terms of OA, we've talked about the local factors, the biomechanical factors, systemic factors. Then what about aging? So there are aging changes that affect your joint function. So sarcopenia, refers to the muscle loss with aging, particularly muscle weakness. With age, we have increased fat mass, less active, some changes in proprioception and balance, and some increase in joint laxity. All of these things seem to be important in why older adults get osteoarthritis. And then there's aging changes within the joint tissues themselves. Cell senescence, we'll talk a little bit about. So with aging, our cells become senescent, and they produce what's called the senescent secretory phenotype, which means the cells are producing these inflammatory mediators, cytokines, and a lot of the things that you see in OA are produced by senescent cells. The cartilage becomes more brittle from advanced glycation end products, and I'll show you a picture of that. There's loss of normal bone structure, or stiffness in ligaments and tendons, and changes in the meniscus. So these are all changes that also are affecting the development of osteoarthritis in older adults. In terms of the decreased physical activity, this is associated with loss of muscle strength as well as increased fat, and there's more inflammation in the fat in older adults, and that is one source of this IL-6 that I talked about from macrophages that come into fat. And so this results in muscle weakness, putting more loads on the joint because the muscles aren't protecting things, and then increased production of adipokines and other mediators from the fat. And then I mentioned already several times, with aging, there's an increase in production of interleukin-6, so that increases systemic inflammation. There's a decrease in production of growth hormones and sex steroids, and that may be playing a role in the changes in joint tissue production. And then there's a change in bone mass and bone quality, which may be playing a role in some of the bone changes that we see in osteoarthritis. And then finally, there's a change in proprioception and balance, which are reduced. And when you see this at a micro level by, say, gait analysis, this has been referred to sometimes as microclutsing. A guy named Eric Radin described it as microclutsing. So it means that because of a decrease in proprioception and balance, you may be changing the load you put on your joint, say when you're walking, but you couldn't really see it if you're watching somebody do it. But if you did something like gait analysis, then you can pick it up. So these are, again, reasons why arthritis is more common in older adults. In terms of the muscle changes, this is really a dramatic CT scan of the MRI of the thigh. And this is a young, active, healthy person, so the muscle and the subcutaneous fat. You can see this compared to an old sedentary person. So their thigh is almost half fat, and there's a decrease in the muscles. So that's one of the aging changes that occurs, in part because of reduced physical activity and in part due to aging. And obesity has numerous effects that would promote the development of osteoarthritis. Changes related to metabolism changes, things that happen in the liver, in the fat tissue, and increased inflammation, which comes from macrophages. So the fat's making these inflammatory mediators and adipokines, and then the joint loading, which is increased as well because of the increased weight on the joint. So all of these things kind of work together. So some of this is related to aging, and some of this is, something you see in an obese younger adult as well. And then there are also changes in the bone that occur with age that could be playing a role in osteoarthritis. So the osteocytes that are in bone, you probably remember osteoblast, osteoclast, osteocytes, those are the bone cells. There seems to be, in particular, a loss of osteocytes with aging, and this may affect fluid flow and other things that are important for response of bone to microdamage. So you have insufficient delayed repair of bone, and this may be playing a role in these bone marrow lesions that we see in people with osteoarthritis. So you see similar findings of a decreased osteocyte density and micropetrosis, which is areas of increased bone and areas of bone loss in OA bone as you do with aging. So one question that comes up is, if osteoarthritis is so common with aging, what's so special about people that don't get osteoarthritis with age, you know? So as I showed, you know, so many people that are older adults get OA. So this was a study that was done in Leiden in the Netherlands. They have a cohort they've been following called the 85 plus study. So to be in this study, you have to be older than 85. And they evaluated these patients, these people in this study for osteoarthritis. And they found a group that had no osteoarthritis. So in this particular study, the people that were 85 plus in this study, there were 63% that had no hip OA, 51% that had no knee OA, and 29% that had no hand OA, and 16% that had no OA anywhere. The absence of having osteoarthritis, surprisingly, was associated with males, particularly knee OA. Not totally surprisingly, because knee OA is more common in women, but not surprising. Normal BMI, you know, so if you have a normal BMI when you're old, you're less likely to go OA. This was a surprising one, history of heavy work. Because normally if you think about heavy work, more joint loading, predisposing to OA, but these people had a history of heavy work and had less OA. So whether or not these are superhumans that can do heavy work and don't get OA because of some other physical attributes, it's not clear, but that came out. And then the absence of family history of nodal OA in the hands, which is probably the genetic component of OA. And then in a second study from this group, they also showed that the people that had an absence of OA had less of this inflammation that I've been talking about. So they had a lower production of interleukin-1 and interleukin-6 when their peripheral monocytes were stimulated. And again, these are the inflammatory mediators that seem to go up with age. So these people have less systemic inflammation than some of these other changes. So this is not a huge study, needs to be repeated, but I think it's kind of interesting. We've been talking about the different risk factors for OA, you know, including age. The end stage pathology is really similar, no matter which risk factors you start with. But what we're learning is that the pathways from these risk factors to developing osteoarthritis are probably different. And this is important because as we develop new treatments for osteoarthritis, a treatment that works in someone who's had a joint injury may not work in somebody who's obese or somebody who's aging without a joint injury. So we may need to be targeting therapy to subgroups of people with OA. And that's an area that we're interested in here in the Arthritis Center, and other people are as well, is how do you differentiate different pathways to OA that could be targeted specifically? And it's just one example. This is a mouse study, but this is something from my lab. We looked at mice that had a knockout of a cytokine called MIF, macrophage migration inhibitory factor. And we found that MIF knockout mice had significantly less age-related OA. So the wild-type mice are shown here. This is an articular cartilage structure score, which shows cartilage damage. The knockouts are here. This is 12-month-old mice and 22-month-old mice, which are pretty old mice. You can see significantly less OA and fewer osteophytes in the knockouts. We took the same MIF knockouts in a younger group, and we induced OA through injury. This is called destabilization of the medial meniscus, where you cut the ligament that holds the meniscus in place. Without going through all the data, basically no protection from MIF knockout in the injury OA model. So this shows you that this cytokine MIF contributes to age-related OA, but not to injury-induced OA, at least in this particular model. So there's different pathways involved. And just to make the point that aging and osteoarthritis are not one and the same, these are femurs from tissue donors and from an OA joint. And you can see the nice, smooth, articular surface on the femoral condyles of a young adult. And this is the histology. This is an older adult that has normal, smooth cartilage. You can see it's just a little bit brown from the advanced glycation end products that form. When you do histology, you can see that there's thinning of the cartilage with age. but this being a normal joint, the cartilage is still okay. And then here's the OA joint. There's osteophytes that are formed here, cartilage loss that you may not see. And this is what the histology looks from that same joint. So you can see that with aging, there are some changes that occur with aging alone, but aging and OA are not one and the same thing. They're different. And in terms of this browning, this even occurs in joints like the ankle. So this is the talus from the ankle. This is just two ankles from a young 14-year-old and a 68-year-old. So you can see this browning that occurs, and that browning goes up with age, and that seems to make the tissue more brittle and affects the mechanical properties of cartilage. So that's another age change that seems to be important in a way. And changes occur in the meniscus as well. So these are different changes in the meniscus. And basically, the changes in the meniscus, injuries shown here, correlate pretty well with the changes in the cartilage. So it seems like when you have damage, aging changes, or injury changes in your meniscus in your knee, the cartilage has similar changes. And just a few more slides on the pathology of OA, or the pathogenesis. The chondrocyte is the only cell that's present in your articular cartilage. So the chondrocyte is responsible for producing matrix and also responsive to removing the matrix. So it does both jobs. In the bone, you have an osteoblast that makes bone, an osteoclast that resorbs bone. In cartilage, it's the chondrocyte that's doing both. And over the years, we've learned that there's a whole host of mediators that are present in OA cartilage that are produced by chondrocytes that stimulate the degradation and inhibit the synthesis. And then there's growth factors that are also present that stimulate synthesis and inhibit degradation. So normally you sort of want to balance in these two sides. But what happens in osteoarthritis is that this side becomes much more active than this side, and that results in production of all these enzymes that degrade the cartilage. And so I don't expect you to memorize all these different mediators that are up here, but the point is, this can't be simply wear and tear. We have an active biological process. Inflammatory mediators are involved in breaking down cartilage, and they just overwhelm the ability to synthesize and repair cartilage. And that's what seems to be driving osteoarthritis. And these enzymes that degrade the matrix are key to all of this. So lots of potential targets for treatment. And then I mentioned repair. So cartilage doesn't repair itself. Here's one example of how you may generate some type of repair tissue. So this is where a surgeon has drilled down into the subchondral bone. And when you drill down to the subchondral bone, there are stem cells, mesenchymal stem cells in bone that can actually migrate up and generate some type of repair tissue. So that's what this is. You can see how different this tissue is than this tissue. So this is a sort of a fibrosis type tissue that's formed rather than forming normal articular cartilage. So people have spent years and years and years trying to figure out a way to regenerate cartilage or repair cartilage, and so far, none of it's worked. So cartilage is just not great at repairing itself, and engineering cartilage is difficult as well. And in terms of aging, did Brian show you the different hallmarks of aging in his STAR talk?
I think a student did.
Maybe a student did? Okay. So this was from a nice review that shows all the different important hallmarks of aging. Cell senescence, you heard some from Brian. And then mitochondrial dysfunction is something that we're interested in, which also occurs with aging. With mitochondrial dysfunction, you get increased production of reactive oxygen species, and we think that plays a role in osteoarthritis. So in terms of cell senescence, mitochondrial dysfunction, oxidative stress, and excessive mechanical loading can all lead to what's called stress-induced senescence. And these are sort of the senescence factors that you probably heard about from Brian. So these are some of the changes that occur in cells with senescence. What's really important, there's a growing appreciation for what happens to the cells as this they become a senescent-associated secretory cell. So it's called the senescence-associated secretory phenotype, or SASP. And the SASP is characterized by production of cytokines, chemokines, MMPs, and certain growth factors. Many of these are the exact same ones you find in OA. So that's why it's felt that cell senescence is really being, it's an important factor in OA, because the senescent cells make the same things that cause OA. And Brian probably showed you this. This is a study, preclinical study in animals using what's called a senolytic, which is a drug that kills senescent cells. And they found that this senolytic, this is this UBX compound from Unity, which is a company that's working on this, reduced the severity of cartilage lesions in an ACL injury model. And then in age-related OA, this is a different method of removing senescent cells on a molecular basis, also reduced the severity of OA. So there's a big interest now in whether or not senolytics are going to be new treatments for OA. And not just age-related OA. It looks like this is an injury-induced model. This is anterior cruciate ligament tear. It seems to work in that as well. So you see senescent cells after joint injury. So this is an area where this company is doing some early phase studies right now to see if it's going to be a benefit to kill senescent cells. I'm going to kind of just skip over this because this is our research, what we do. We're really interested in how aging, oxidative stress related to mitochondrial dysfunction lead to OA. Basically, this balance of anabolic and catabolic signaling that I've shown you, this is all in response to changes in the level of reactive oxygen species that leads to OA. And I've mentioned the change with age formation, mechanical changes that lead to OA. Just some data to show that reactive oxygen species are increased with OA, and with aging, there's a lower level of antioxidant enzymes and increased production of reactive oxygen species that are important. And so you basically, with oxidative stress, there's a change in the balance between the amount of ROS that are being produced and the antioxidant capacity of the cell. This causes damage to occur, oxidative damage in the tissue, but more important, it also alters signaling. And so our lab has been studying how cell signaling has changed in response to this redox imbalance and how that contributes to osteoarthritis. I'm going to skip this. This is mouse stuff. Skip the mouse stuff, and just end with some conclusions since we're out of time. So I hope I've convinced you that there are aging changes that predispose to OA or affect the development of OA that are both systemic changes as well as local changes within the joint, including changes in joint tissues, the cartilage, meniscus, bone, all of the joint tissues being involved with OA. Cell senescence seems to be a key feature that's associated with aging, but also with joint injury. And that's a new target for therapy because the senescent cells make these mediators that are found in the OA tissue. And then oxidative stress is another key player in aging and osteoarthritis, not just from damage, but also from altered cell signaling that we can talk about at some other time. And I just want to show, this is my lab group, at least how it was about a year or so ago, that worked on research with me. So this is a lab group. We have lots of collaborators. We have funding from lots of different sources, NIAMS, NIA, and so forth, in terms of the research that we do. So with that, I'd be happy to answer any questions. Go back to the summer slide. Anything that you didn't ask along the way.
So if a patient arrives to you with radiographic but not symptomatic AOA, do you suggest to do anything as of now because there's no interventions that would really treat it?
Right, so at this point, what I would suggest to say it's somebody who's obese, I would say to help reduce your chance of getting symptoms, it would be good to lose weight. Because I think there is evidence that that person who's obese is at higher risk for getting OA. And even though they're not symptomatic now, if they can lose weight now, it might help. And if they're not exercising and their muscles are weak, recommending exercise. So sort of the typical things that you might think about in terms of non-pharmacologic measures, but nothing pharmacologic in someone who's got X-ray changes but no symptoms. But obviously, when people come to us in clinic, it's because they have symptoms, you know, rather than just a radiographic change. Other questions?
Like if you get a meniscal tear
Yeah.
in soccer when you were 16,
Uh-oh, did this happen to you?
it did not happen.
Okay.
It happened to a few of my friends.
Yeah,
So they're like
they're higher
much
risk,
higher risk.
right,
for
of getting
developing.
away as they get older.
Is there anything they can do to prevent their risk?
So right now, only maintain a healthy body weight, maintain, you know, good, healthy muscle strength, but nothing that's proven yet to prevent them from getting OA in the future. So that's a group where once we have treatments that actually slow disease progression that we would want to target. Someone who's had a meniscal injury, an ACL injury, because we know they're at higher risk. So targeting that group with an intervention that works, you know, would be sort of a way to start. Otherwise, it's hard to target someone who's getting older. You know, like when do you start the intervention? How long do you treat them for? But if it's somebody who's had a joint injury and you know that leads to OA, that's a group where after the joint injury, you'd start this magic treatment and, you know, try to prevent them from getting OA.
I know you mentioned there possibly being a benefit to heavy workload over time.
Well,
There
just in this
Okay.
study of older adults, because in general, the relationship between occupation and workload in OA would suggest that, for example, with knee OA, if your job involves carrying heavy loads and knee bending,
Like landscaping.
yeah, you're at higher risk for OA. And hand OA, people that work like in cotton mills or things where you use your hands a whole lot, they're at higher risk for hand OA. So there's this relationship, you know, it's all observational epidemiological data that heavier workloads do result in a higher risk for OA. So that's why it was sort of surprising with this Leiden study, 85 years and older, less OA, you know, that it didn't seem to match up with what we see in everybody else. That's why I said maybe these are just super humans that can withstand all of that workload and they increase their muscle strength and everything else and we're at lower risk for getting away, but not the typical person.
So, like the Walk with a Doc
Mhm.
initiative, there's benefit, right, to losing weight, to being active and mobile if you
Right.
have large joint OA.
Mhm.
Is there a fine line though between what's beneficial and what's potentially harmful? Like if you're inducing inflammation, like say running marathons and you have hip OA, is that going to make it worse?
Well, that's a good question too. So there have been some, you know, observational studies of marathon runners that are over the age of 50, and they compared them to people that are age matched that weren't runners, and found that the runners actually had less OA than the non-runners. But this is a group that's been running and made it, you know, past age 50 and are still running. So they probably didn't have any joint injuries or other factors, or they would have probably stopped running. So like if you tear your ACL or tear your meniscus, if you run on that joint, you might be more likely to get OA because you've lost the stability of the joint. But if you have a normal healthy joint, you're not malaligned and you haven't had a joint injury, running stimulates your cartilage, you get more nutrients into the tissue by loading it, and so it's probably beneficial. But if you have an abnormal joint, if you already have OA, probably running isn't great, but walking is okay. There's been plenty of walking studies, and we've been involved in them, of people that have OA that can be in a walking program. The caveat to that is, in all of the walking studies, we excluded people that had end-stage bone-on-bone OA because they don't tolerate walking as well. They do better with, say, pool exercise, aquatic exercise, where there's, you know, support from the water. They seem to do better with that. So part of the answer depends on how severe your OA is. If it's mild to moderate, walking is fine. Doesn't make it worse. You know, if you're doing something that causes more pain, obviously you back off. And these are 18-month clinical trials too. It's not like it's a short-term walking program. that have shown that it's beneficial, not harmful.
So clinically, pain is a pretty good measure of whether what you're doing is working or not.
Yeah, I mean, I think that's the best measure we have, right? Because it's our body's natural response to you're injuring your tissues, that, you know, you feel pain, except for people that have like central pain from fibromyalgia, which is a whole different story. Because in those cases, you can't find any tissue injury anywhere in people that have fibromyalgia. So for them, getting them to exercise, you have to convince them that they need to kind of fight through their pain because it's okay to keep going because their tissues are fine, their joints are fine. It's a different type of pain, it's a central pain. But the pain that you get from your joints, you do need to pay attention to that. And so that's how you can adjust what you do in terms of activity. And that's one thought, you know, we talked about the tanezumab study just briefly this morning as an example of a clinical trial. The part we didn't talk about was the progression of osteoarthritis in a subset of people in the tanezumab trial. So that's one of the side effects of blocking nerve growth factor, is that there's a subset of people where their osteoarthritis progresses more rapidly. And the thought is anti-NGF reduces the pain to the point where maybe they're using their joints more than they should, or they're not getting the pain signal to be more careful. And so they're loading their joints maybe abnormally and getting a more rapid progression. That's one theory for why anti-NGF has this risk in some people for more rapid progression of their OA. And that's something that's going to limit the use of it clinically to treat patients because, you know, if you're someone who doesn't want to get their joints replaced, you know, I wouldn't recommend going on anti-NGF because you may be at higher risk for needing a joint replacement down the line from getting this treatment.
A little off topic.
Yeah.
It may or may not be personal, but is there any research or evidence of postpartum accelerating the progression of arthritis?
Not postpartum. There's some evidence that postmenopausal, where you drop estrogen production, that may be one reason why women get more, say, knee OA than men. It may be that estrogen plays a role. It's been hard to tease out. The Women's Health Initiative, where they, you know, used estrogen versus a placebo, they did sort of a sub-analysis and found there was fewer hip replacements in the women that got estrogen. We did a study a long time ago with cynomolgus monkeys. They are used a lot in estrogen studies. They had their menopause induced by ovarectomy, because with aging, monkeys don't get menopause until they're really, really old. So they had ovarectomy. They either received estrogen replacement or placebo. The monkeys that received the estrogen replacement, this was like a 2-year study, they developed less OA than the monkeys that received the placebo. So in the monkey study, estrogen was protective. So, you know, there's some evidence that estrogen may be playing a role in a way, but in terms of postpartum, I don't think there's any data that there's an association there. It's more with postmenopausal.
Were the estrogen replacement monkeys comparable to non-surgery monkeys? Is that something?
So there was no surgery in this study. This was naturally occurring OA in the monkeys. So monkeys get naturally occurring OA just like humans.
If the monkey did receive ovarectomy, but then just, you know, had the regular estrogen.
No, they don't do it that way because since monkeys don't go through menopause naturally, the monkeys that didn't have an ovarectomy would sort of have a normal level of estrogen. So they didn't put estrogen on top of the estrogen that was already being made.
Is it comparable, or the Rex OA comparable to the normal monkeys?
Well, see, all the monkeys had ovarectomy.
Okay, so there was that.
One group received estrogen, one group received placebo. The ones that received estrogen had less than the placebo one. Okay. And the overectomized placebo-controlled monkeys would have less OA than, say, a monkey that didn't have ovarectomy. Maybe that was your question.
My question was the rate of OA in the ovarectomy monkeys that received estrogen?
Yeah.
Comparable to just normal monkeys?
Yeah, monkeys that did not have ovarectomy. Right, yes.